code blues, no more RRTs. Is it just more than a second eye, or the now and the future, diving into the future of telemedicine? So I'm going to segregate this into 5 short topics: evolution of healthcare and the need for tele-ICU, cloud docs, our baby version of adaptation of tele-ICU in Ramesh Hospital, evidence-based facts pre and post tele-ICU and the recent trial, is it just a second eye, and the diving into the future of tele-ICU. So we all began 300 years ago with messages being sent by carrier pigeons, smoke signals, message in the bottle, Pony Express, telegrams, balloon mail, telephones, pagers, and cell phones. And now we have evolved into much modern technology where informal caregiving and spiritual healing has transformed into science-based technology. So the basic tools and observations have gone up to high-tech and data-driven connected systems which are integrated into telemedicine. So why tele-ICU? It's a centralized collaborative care model which consists of intensivists, critical care nurses, clerical and non-technical staff continuously accessing the patient's data throughout 24/7 and providing alerts. So it also helps in providing quality care in distant area, round-the-clock availability, reduction of the cost, better results with the latest technology, helping in early diagnosis and improving the level of existing ICU care. So there are many more economic benefits which help in reduction in the length of the stay, reduction of the cost, reduction of the overtime, scalability of the beds, upgrading to more than 2,000, and accreditation and easier settling of insurance claims and faster progression. So what actually it helps is round-the-clock surveillance from central command center. It enables that collaboration and consultative support across the specialties and helps in triaging patients in ER and ICU. So a decade ago, this is where we actually began. Adaptation of cloud docs is a baby version of Ramesh tele-ICU. It incorporated three main real-time monitoring essentials. We did input continuous data streams from electronic health records, monitors, and lab systems, which processed through AI algorithms, analyzing the deviations and patterns, and then outputting actionable alerts for early interventions. So we created a network using fast Wi-Fi across the hubs. So AV devices are incorporated into telemedicine robots, which are deployed at each site, and alerts were given through that. So almost 18 to 20 outreach centers, all the patients who are sicker and need ICU care and expert advice were being incorporated into telemedicine network across Ramesh Hospital. So how did this work? It did work with the command station, which recognized all the issues where the patients were incorporated through the central command station. 24/7 data was being monitored, and dual assessment has been made in terms of audio-video connection through a database and focus on the multi-parameter monitoring. So combining these two, AV connection and multi-parameter focus monitoring, the dual assessment has been made and alerts have been generated. So this is the command station which has been visible in the central area where there's a doctor and nurse support throughout 24/7 where they give programmable, actionable alerts. So direct point of care alerts have been generated. You can see the white thing there, which is a robot docking station where alerts will be audible into the respective wards and ICUs. So announcement of tele alerts go through as quickly as less than 5 seconds within a deviation of either ECG or the stats decrease or any other blood pressure decrease. This technology has been incorporated into ICU and ER as well, while CPR has been ongoing, and much more advisors and alerts have been incorporated into that. Tele-ambulance has also been connected to that, to the central command station, where we quickly know what patient we are getting into the ER, how sick the patient is. We could be ready for whatever infusions we need, whatever expert opinions we need. So history and drug medications, everything, including drug allergies, everything has been communicated through the tele-smart ambulance, where there's a two-way interface where we can ask more questions and they respond through that. This is one of the examples of the recent case where there is a 38-year-old female who's had emergency laparotomy for obstructive hernia on day 2 post-operative. She developed shortness of breath and she developed severe tachycardia and ventricular tachyarrhythmia. As less as 4 seconds was the response time for the tele-ICU team, which gave the response for the actionable alert for the ventricular tachyarrhythmia. It's also been incorporated in the operation theater, where this is on the left side we can see the monitor, continuous monitoring of the arterial blood pressure, saturation, heart rate, and respiratory rate has been seen. And on the right side we can see there is a dual parameter monitoring. So we are proud to say this is one of the recent trials which has been conducted across Aster Ramesh Hospital, across all the ORCs and ICUs. So this is a tele-intensive care unit associated early recognition of in-hospital hemodynamic events. We can see the names there. Dr. Ramesh's name is there. Mine, Dr. Shilpa Madam, Dr. Karthik, everybody's involved in this study. It's as big as, it's the second biggest in the Asia, this trial. So it incorporated 5,253 adult patients and total of 2,278 alerts have been generated. So what it did emphasize was the early recognition and verification of hemodynamic alerts in tele-ICU were associated with improved mortality and clinical outcomes and lower risk-adjusted mortality on comparison with Apache 2 score. So the program also coincided with the observed reduction in in-hospital cardiac arrest and reproducible approach for in-hospital cardiac arrest recognition and prevention in low and middle-income countries. So the clinical significance of this study was it emphasized the role of tele-ICU in strengthening early recognition of in-hospital cardiac arrest in the chain of survival, so that we can break the chain of survival as early as we can. The findings support broader strategies with decreased preventable deterioration and potentially improved outcomes quite early. This study emphasizes particularly where there is shortage of intensivists in rural areas and ORCs where there is expert opinion needed. In this graph we can see the length of stay in high-risk patients. So as the length of stay increases in critical care patients, the number of actionable alerts have gone up and the patients who have gone out of hospital also go up. So thereby the mortality, overall mortality comes down. So in comparison with the largest trial that has underwent in the world regarding tele-ICU, this is the telescope RCT. So it's done in Brazil. It's as big as 15,000 patients, done in 30 ICUs. So the primary outcome was length of stay. What it did say was there is no difference in length of stay between tele-ICU and non-tele-ICU monitored patients. But it ignored the fact that the mortality has been better and the patients who have gone out of hospital increased significantly in number. And also the in-hospital cardiac arrests have come down. So these 6 are the studies which were done in US. All the collated studies have showed the equivocal pattern as depicted in reduction in the mortality by 30%, 17%, decrease in length of stay by 16%, incidence of cardiac arrest, and most importantly, overall reduction of the healthcare cost burden. So in short, in summary, tele-ICU had 10% reduction in hospital-acquired infection cases because there is no direct contact with the clinician, 18% reduction in ventilator days, 17% reduction in length of stay, 32% reduction in ICU mortality, which is a big number, significant number, and 27% reduction in transferred cases to other bigger units. Overall workload reduction was 33%. So all these numbers are quite significant in day-to-day basis. One other fact which was observed was pre-tele-ICU and post-tele-ICU. If we see, tele-ICU is particularly useful during evening, out of hours, and on the weekends. So if you see the graph, the number of patients who are improved have significantly gone up in the PM time after the usage of tele-ICU. So the overall mortality is much lesser in out of hours and over the weekends. Coming to the program acceptance and integration of tele-ICU, whenever the best practice guidelines have been adhered and protocols have been followed on the advice of tele-ICU, it's of significant benefit. There is also social learning theory involving and empowering the on-site doctors in clinical decision making and upgrading their knowledge on a day-to-day basis. So these two are the main things that lead to the success of tele-ICU. Tele-ICU is a well-accepted clinical model in abroad, but still a relatively new concept in India, and it holds immense promise for the future of intensive care medicine. So the future of tele-ICU rests within three main principles based upon artificial intelligence-powered analytics, integration with wearable technologies and sensors, expanding the care to high-turnover emergency rooms. All these things help in scalability of the beds and accessing remote areas where there is critical care need. Is tele-ICU just a second eye? No, it's not. Because as we embrace artificial intelligence-driven future into critical care, we are not replacing the human touch. We are not replacing the emotions that the on-site doctors go along with the patients. Instead, we are augmenting the abilities and capabilities, allowing healthcare providers to focus more on what matters the most. So what matters the most? That's nothing but compassionate, high-quality care to our most sickest and more vulnerable patients. So as technology advances, tele-ICU is positioned to enhance critical care outcomes and redefine the patient-clinician relationship. It's just not a tool, it's a lifeline bringing critical care into expertise where it needs the most, whenever it needs the most. We are just bridging the gap between clinical excellence and technological innovation. Like all innovations, tele-ICU also has some challenges. It is technology dependent, it has privacy concerns, it loses the emotional touch and humanitarian touch what a physical doctor can do bedside. It has regulatory hurdles, and the integration of telemedicine into existing workflows is always a challenge. So continuous alerts 24/7 given to the nurses or doctors who is stationed in the tele-ICU, they get alert fatigue. So it's very hard for them to focus 24/7. So adequate workforce personnel are also needed for monitoring tele-ICU. Diving into future of critical care, tele-ICU, when it's married with artificial intelligence, it's not just about the technology, it's about creating more responsive, efficient, and effective critical care environment. As we look into the future, the integration of AI in tele-ICU systems promises to revolutionize critical care in many ways. It helps in early interventions, resource optimization, and continuous learning data streams. So as healthcare costs continue to rise, these innovations provide a path for improved outcomes and more efficient patient-centered care delivery. Thank you.